Okay, so this is our talk on the bone scan. So what we have here is a workhorse, and our workhorse for skeletal imaging is methylene diphosphonate, or MDP, typically tagged with technetium. So let's just review some normal physiology. So let's pretend that we've got a small microfracture in bone here. So what's the first thing that's going to happen? Team osteoclast is going to show up, and the first thing that happens is actually a resorption phase. This is why when you see fractures healing, they become slightly more lucent early on. So team osteoclast shows up, proceeds to chomp a hole through the bone there, get some resorption, basically file the edges off so that it's nice and smooth. Then they're going to bail, make room for the osteoblast to arrive and build. So the osteoblast, blast with a B, do the building, new bone. They get in there, build up some new bone. All right, so there you go, something like that. So MDP is going to plug itself into this process essentially as a building block. So it's going to be utilized in this osteoblastic phase, not in the osteoclastic phase, but in the osteoblastic phase. So it would get laid down. It's going to concentrate during this mineral phase where crystalline hydroxyapatite and amorphous calcium phosphate are going to sort of getting smashed in together. So this is important take-on point here. Uptake is based on the fact that most focal skeletal lesions will excite an osteoblastic reaction. And there's going to be an increase in vascularity during this healing phase. Now, it's not specific, but it's pretty sensitive for a lot of different stuff. So essential elements are blood flow, vitamin D, and osteoblastic activity. So if you look up in books what the mechanism of MDP is, you'll see this word chemosorption. So what the hell does that mean? Basically, it's a kind of absorption which involves a chemical reaction between the surface and the adsorbate. So you've got new chemical bonds basically made at the surface. Something like that. A normal bone scan is going to show higher activity in parts of the skeleton where there's trabecular bone, spine compared to the shafts of the long bone, where there's more cortical bone. So look at the spine and then look at the shafts of the long bones. Notice that the spine is a little bit darker. It's supposed to look like that. Also notice that you can see the kidneys faintly. This is a normal distribution. Spine, kidneys. So as I mentioned before, the workhorse of skeletal imaging is this methylene diphosphonate. But you have to prepare it and to make it usable, because what you're actually imaging is not the MDP. You're imaging the tech. So you've got to tag the tech to the MDP. So this requires preparation from a kit that has both MDP and a stannous ion. So you add free protectanate and the stannous ion reduces it so that it will bind to the MDP. So you need both of these guys. Free tech, stannous ions, and then you get a binding procedure there. Boom. There's your tech MDP. if you don't have enough stannous ion, or if you get air into the vial or the syringe, that's going to cause oxidation, the air. You might end up with free tech. So we've got some tech in the vial that isn't tagged to the MDP. So not have enough stannous, so tech's just sort of floating in there. And then when you inject it, you're going to see 3 free tech, which is salivary gland uptake, thyroid, stomach uptake. So you can have contamination from air. You can have contamination from water. So air contamination is a more common scenario. We've got our free tech. We've got our stannous. Free tech goes in the vial. Stannous goes in the vial. We got our technetium MDP. But then as we go to get ready to inject it, we draw back, pulling some air into the syringe. What's going to happen is this is going to have, instead of having, we needed that reducing effect to make it stick, this is going to cause an oxidation event, which is going to result in free tech being in the vial. Now the other situation is if you accidentally get some water in there. So water plus technetium plus tin is going to end up creating technetium dioxide and tin colloid. All right? So you're going to get clumps of stuff. That's not helpful for imaging. And that clump of stuff is going to go to the liver. So water contamination is going to cause hot liver. Air contamination is going to be free tech, which is salivary glands and gastric stuff. So don't put air in the tin. Don't put, if you forget to put in the tin altogether, you're going to get free tech because you need it as a reducing agent. If you put in air, you're going to end up with free tech, stomach, bowel, salivary glands. And if you put water in, you're going to get these technetium dioxide and tin colloid, which is going to cause clumping in the liver. So let's do some cases. Bunch of cases here. All right. What are we seeing here? So this was supposed to be a bone scan. I'm not really seeing the bones, but what I am seeing is hot stomach, salivary glands. So decreased skeletal uptake, stomach uptake, thyroid uptake, salivary gland uptake, free tech. So what happened? Tech got some air in the... we either got air in there, or he or she neglected to add the stannous ion. All right, next case. Whoa, it's just sort of black. All right, so I will tell you that you show this case to your tending, and her face turns blood red, and she clenches her fists together so hard that her fingernails dig into her hand, like meat of her hands, and they start bleeding. And she begins to tremble in a full quiver, which really scares you. A single drop of urine comes out of your urethra, and because you think that she's mad at you, which she is, but she's more angry at the tech. So she jumps up, runs out of the room, screams at the tech. A couple of minutes later, the tech comes back and has this picture, which looks pretty good, right? So what happened? This is the wrong window. So remember, there are these energy windows that are aids in discriminating between true photons and scatter photons. And they work by excluding photons of low energy from registering as true events. So in this case, the energy window was set too low at the range of thallium, which would be 60 to 80 keV, and then it was told basically to exclude anything above that, which would include the 140 keV photons of technetium. So basically accepted only the scattered photons. So here's your tech window, here's your scatter. That's normally excluded, but if you set the wrong window, as in here, that's what you're going to get. You're just going to get a bunch of scatter. If you set the window here, then you're going to get a pretty picture. All right, next case. Well, we've got multifocal cancer, right? So this is, so here's the question. Where is tracer normal? Bones, obviously. Kidneys, assuming it's not a super scan. A little bit in the bladder. You can have mild symmetric uptake in the breast, especially in young women. Little low soft tissue, right? You can sort of see the faint outline of their skin. You can tell if they're big and fat sometimes, right? And then you can see it in the growth plates of kids, right? Why? Why would you see it there? Well, remember the mechanism, right? If you've got osteoblastic activity, if you've got bone being turned over and built up, then you're going to have tracer uptake. So that's normal. All right, what about this one? Zoom in on that. So this is an Ant Mini. There's only one thing that looks like this. Super hot, very heavily concentrated. It's involving the extremity just from here down. Right around here is probably where the injection was. Probably over here, actually. So this is arterial intravasation. So when they did the injection, they got some in an artery, and it all just, arteries go distal, right? So it went to that whole arm and stayed there. Got a little bit in the vein too, or circulated, because the scan otherwise looks normal. All right, what about this one? Move it over here. Get a zoom in on that. So anytime you see something weird like this and you're offered a next step, I would look at their imaging, either X-ray or CT or something. And this is what you see. So this is myositis ossificans. This also is, MTP gets laid down and there's in this situation. All right, next case. This makes a great next step question, so I will draw your attention to the shins and to the femurs to a lesser extent too. This so-called tram tracking, where we've got hot here, hot there, like this, sort of like these lines like that. So if you're asked for a next step question in this, and even though there's a couple of things that can do this, for the purpose of multiple choice, it's always a lung cancer. So this is hypertrophic osteoarthropathy. The finding is a tram line or tram track line along the periosteum long bones. You can see it with lots of stuff, things that cause hypoxia, cyanotic heart disease, any kind of pulmonary pathology, but 10% of the time it's actually seen with a lung cancer. All right, next case. Look at that. Too much in the kidneys, right? That's too bright. Almost looks like an octreotide scan, except it's got bones. It's really, really hot, and it doesn't have spleen. But it's super duper hot. So a bone scan with very hot kidneys is something that you can see with chemotherapy. It can also be seen with urinary obstruction. now we've got a comparative one. So we've got a situation where the entire kidney is hot, contrasted to a situation where just the cortex is hot. So hot that the cortex is, their internal control is the adjacent lumbar spine. So, really hot renal stuff can be chemotherapy or obstruction. Just the cortex, you should think about hemochromatosis. All right, next case. We're seeing a bunch of uptake in the spleen. So when you see that, too much in the spleen, that is sickle cell. That means that you've infarcted your spleen. And you're supposed to assume anytime I say infarcted spleen that that's a sickle cell thing. All right, another comparative case. We've got this person here, got some rib lesions. But then look at this. Wow, look at that. So, all right, I'm going to window this first one for you. Notice that this also has breast uptake. But notice that it's faint and it's symmetric relative to this, which is really hot and unilateral. So that's always abnormal. So symmetric physiologic breast uptake and a variety of scans can be normal if it's faint. Asymmetric focal uptake like this in the breast is not normal. That's something bad. So that could be mastitis, it could be an inflammatory breast cancer, or something really nasty like that, for example. All right. What do you think of that? So how old do you think this patient is? It's a kid, right? How do you know it's a kid? Because growth plates are open. So what kind of badness do kids get in the metaphysis of long bones? It's an osteosarcoma, right? It's a classic location. It's the right age. See the gamesmanship for figuring out the age? That's a bone scan thing. Look for those. Here's another sort of younger person, right? Still got this growth plate stuff going on. More faint. Notice the scoliosis. So this supposedly has a double density sign. If you squint, maybe you can see that. Or it's hotter in the middle. Central hotinitis, scoliosis. What kind of history do you think this kid has? I'll bet you he has pain at night that gets better with aspirin. You think so? Osteoid osteoma. All right. So that shoulder, right? What do you think that is? I'll tell you that's not degen. Could be, probably, right? It could be like rotator cuff stuff. Because this here's degen, right? AC degen. There's degen there, too. Glenohumeral, probably. Correlate with a plain film. What's that now, right? Rings and arcs. It's classic. Enchondroma. Common thing. So we've got a whole bunch of different bone lesions. We've already looked at a couple that are, we looked at an osteosarcoma, right? That was hot. That's a malignant thing. That's hot. So what benign things are hot? Like, do you have to memorize all 30 of these fucking things? So I would say no, don't do that. It might be easy to remember that unicameral bone cysts tend to be cold as long as they don't have a fracture. So no fallen fragment sign. And it might be useful to remember that these things tend to be really hot. So osteoid osteoma, we looked at one of those. Osteoblastoma, these guys are similar, right? Fibrous dysplasia can be hot. These guys are similar, right? So two similar things, fibrous dysplasia, all can be hot. These are benign, right? Anything that's a malignancy, well, especially osteosarcoma, because it's a bone-forming tumor, right? It's going to be very hot. So I would just try to remember those two lists. And if you can only remember one thing, I would remember this and just assume anything else is hot. Got to look at the plain film, so next step would be look at the plain film. You could probably figure it out from there. So what about that? What about that right there? Some people might say that looks like candle wax dripping. So that's a buzzword for melorhiastosis. It's a meaningless thing. Looks like might be scary to somebody that doesn't know what they're looking at. Tends to follow a dermatonal pattern. All right, next case. Ant-Mini, probably the most classic Ant-Mini of all bone scans. This like hot hemipelvis. So Paget's, primarily in older people, right? 4% at 40, 8% at 80. There's like 5 classic ways to show it on a bone scan. One is the hemipelvis, right? Another one is the hot enlarged femur. Super hot skull. An expanded hot vertebral body that involves the entire vertebral body, not just part of it, not just the posterior elements or something. And then, of course, there's a metabolic super scan. Same kind of look that you see with hyperparathyroidism on a super scan. So here's your pelvis. Here's your hot femur. So that's Paget's also, very classic Paget's. All right, now we got a hip arthroplasty, and now we're going to look at the bone scan, and we're going to see this right here. So prosthesis evaluation can be challenging. You know, you're trying to differentiate infection from aseptic loosening. It's a common reason for a nuclear medicine doctor to get involved in this kind of situation. Basically, bone scan findings are pretty nonspecific, but you can see, so here are like some pearls. You can see increased tracer activity in the hip up to about a year after you place it, even longer if you do a cementless arthroplasty because it's going to wiggle around in there a little more. Typically, you would see diffusely increased activity on MTP. In the case of infection, more focal, and it tends to be more focal along the stem and the lesser trochanter with loosening. Those are like the wiggle spots, right? So look at this case. Notice where the hot spots are. They're right on the bottom part, and then they're at the lesser trochanter. So this is classic for wiggling, loosening. It's not specific either, but if you see it in a test or in case conference, that's what it is. Now, to really know the difference, you can combine a Soffer colloid exam to map the bone and then white blood cell. So, again, how do you know it wasn't infected? Well, you know, multiple choice, when you see this kind of pattern right here like that, it's always loosening. So, plus, I mean, it's going to be a different clinical story, you would think. In reality, it could totally be infection. So, I mentioned that you can do this thing with Soffer colloid and then white blood cell scan. So TEC can be tagged to Soffer colloid, and the idea is to get a normal localization to the bone marrow that is. You can actually perform TEC Soffer colloid studies to map bone marrow in patients with sickle cell to look at their marrow expansion and areas of bone infarct. The major utility, though, is combining it with white scan or gallium. Both TEC Soffer colloid and white blood cells will accumulate in normal bone marrow, but it's in a spatially congruent way. In other words, they overlap. So here's a Soffer colloid, here's a white blood cell scan, so something like this. But in areas that are infected, you'll have downregulation of the Soffer colloid and upregulation of the white scan. So like that. So less uptake in infected bone for Soffer colloid and more uptake in an infected bone for the the Indium white blood cell scan. Now, it can take about a week after the onset of infection, so if you have a hyperacute infection, you can still miss it. Now, when you're in the spine, white blood cell scans frequently fail to migrate, so you might end up with a photopenic area there, so sort of double photopenic. And this is why gallium is preferred for osteomyelitis in the spine. So take-home point, white blood cell scan sucks in the spine. So your next step would be to use gallium instead, and gallium is going to be hot. Sulfur colloid is still going to have a less uptake. All right, so next case, right there, right, versus there. So I show a similar case to this in the MSK lectures, just sort of demonstrating the distribution of a bisphosphonate fracture, which is on the outside, versus a conventional stress fracture, which is on the inside. So especially when it's bilateral, you can really think about bisphosphonates fractures. So they inhibit osteoclast. That's their mechanism for keeping the mineralization high in the bones, is by stopping that normal turnover. But it increases the risk of a stress fracture. They usually need to be on the meds for a while, and like I said, it's often bilateral. You often see this hyperostosis that occurs on the outside first, and then you can see a fracture starting there. All right, so does a negative bone scan exclude a fracture? Sort of. It depends on the timing, right? What about the age of the patient? Does that matter? Because I'm asking the question, it probably does, right? So let's talk about time after fracture. So typically abnormal in a day, 95% of the time, and in 3 days, 100% of the time. So in a patient younger than 65, if you've got a normal bone scan a week after injury, pretty much excluded a fracture. Now, if you've got a guy that's older, let's say older than 65, it's less reliable, especially early on, and 80% of the time, so 20% of the time you could have a normal bone scan one day after. So if you're thinking that this person might have a fracture, cold fracture, or like it's an elder abuse situation, it's probably better to image them at a week to be sure, relative to image them like an hour after they had the injury. So how long do they stay hot? A while, depending on the bone, right? So, in a year, you're still going to have some uptake. So the point is that fractures can take years to normalize on a bone scan, although most are normal at 3 years. All right, so it's a normal tracer here, a little bit of soft tissue stuff, right? What about this right here? We'll zoom in. It's supposed to look like a Honda sign or an H. So this is a sacral insufficiency fracture. Some people call it a butterfly also. Osteoporosis is the most common cause, but you can also see it in somebody who's had radiation, like maybe like a prostate or a cervical cancer or something like that. All right, here's another situation. I'm going to show you 3 bone scans, time 0, 3 months, and then 6 months. Now notice that we had multiple lesions here in the spine and in the ribs, especially these ribs. And then in 3 months, it looked like it was getting worse. And this is a patient with breast cancer, let's say. And then in 6 months, it gets better. So basically, the study obtained 3 months. The anomalies look more intense, and there are new anomalies. And then they appear to have resolved. So this is the so-called flare phenomenon that occurs during treatment, where you can see things sort of focally become worse. They're not really getting worse. They're just flaring as a reaction to the chemotherapy. All right, next case. So what if we had an area of lucency here? Okay, so we talked about stuff that was hot on bone scan. What about stuff that's cold on bone scan? Or what if we had a spot that was, let's say, cold in the hip? The dreaded cold lesion. So, artifacts, like from a prosthesis, like a shoulder prosthesis or hip prosthesis, in those classic locations. The spine, you think about radiation change, especially if it's a full segment of like 6 vertebrae. And then if they're everywhere, then you got to think about things that are lytic. So lytic metastases are really hard to see, like myeloma, renal cell, thyroid, and neuroblastoma. That's why, MIBG scans are way better for neuroblastoma mets than a bone scan. All right, next case. Notice these segmental ribs. So when you see that, that's classic for rib fractures, right? Because most rib fractures are multiple like that and in a row. What about that right there? Bunch of segmental things. So these are transverse processes, right? So in a trauma, how like once you see one, you usually see the one above and one below, like when you look closer. So things in a row, transverse process fractures. What about this? The single lesion. So as a general rule, when you see a single hot lesion, the false positive rate for attributing this to an incidental or to a MET is pretty high. Only about 15% of patients with proven METs will have a single lesion. And usually when you do, it's in the spine. In other words, 80% of the time on a single lesion, it's benign. Now there is one classic example, which is this. The sternal lesion in a patient with breast cancer, 80% of the time that's cancer. So that's the classic single lesion that actually is a cancer. Otherwise, the single lesion is usually not. Exception to a rule. There's your breast cancer. Buy that fast. Unilateral soft tissue uptake, breast cancer. All right, so got 2 cases here, neither of which can I see the kidneys in. So these are the super scans, but they're different, right? So super scan occurs in 2 flavors. It occurs in the diffuse METS flavor. Breast and prostate are the major culprits for that. And then it occurs in the metabolic flavor, which is like hyperparathyroidism, and I mentioned that Paget's could do that as well. So how do you tell the difference? You look at the skull. The hot skull is going to be the metabolic ones, hyperparathyroid. And then the cold skull is going to be your metastatic. All right, so let's talk about this thing called the 3-phase bone scan. So you don't have to, pretty much the bone scans we've been looking at before are like a delayed bone scan, but you can do imaging early for flow. Notice the vasculature here lighting up as we go along. And then you can do, since it's a 3-phase bone scan, so flow first and then pull, which is like an early delay. And then you get an actual delay. So that's the 3 phases of a bone scan. Flow, pull, and the delay. So it's good to have a list in your head of things that are 3-phase hot. Um, for example, this. So phase 1 hot, phase 2 hot, phase 3 hot, especially here, right? So this is osteomyelitis. So if it's 3-phase hot, that's always osteo, right? Now it can be all kinds of stuff. So there's a big long list. It's easier actually to think about stuff that's not 3-phase hot. So for example, this. So, this is the situation where we've got hot on flow asymmetrically there and in the pool, but the delayed phase is normal, it's symmetric. So this is cellulitis. It's probably the main cause of, this is the reason that you do an extremity 3-phase bone scan, osteomyelitis versus cellulitis. Osteomyelitis is 3-phase hot, cellulitis is only 2 phases. And because so many things are 3-phase hot, it would be easier to write the multiple choice question as a which of the following is not, and making cellulitis the answer relative to which of the following things is hot on a 3-phase bone scan, because a lot of stuff is. Here's just one more thing that's got sort of a classic look on a 3-phase bone scan, especially for an extremity, and that's reflex sympathetic dystrophy, RSD, or some people call it complex regional pain syndrome. You see it after strokes or trauma, and the classic descriptor is this periarticular uptake on delayed scan. Now you can see uptake involving the entire extremity, and in the literature it'll say 1/3 of adult patients with documented RSD do not show perfusional anomalies, which probably means they don't have RSD. It means they're faking it and they need a rheumatology consult for fibromyalgia. Rheumatology. Monday, rheumatology clinic is fibromyalgia. Tuesday, rheumatology clinic is fibromyalgia. Wednesday, rheumatology clinic is people who have lupus. Thursday, rheumatology clinic is people who think they have lupus. And Friday, rheumatology clinic is for miscellaneous ankle spine arthritis, psoriatic arthritis, and stuff. So, the life of a rheumatologist, just as glamorous as it sounds. So, RSD, periarticular uptake on delayed imaging. All right, so that's the end of the bone scan lecture, and the next Nukes talk is going to be a pulmonary one.